Today's News of the Day press briefing. I'm Dr. Richard Shilsky, ASCO's Chief Medical Officer and moderator of today's briefing, and want to welcome all of you back again. In just a few minutes, you'll hear from the authors of 4 studies that will be discussed in ASCO's plenary session later today. These studies, this session features studies deemed to have the greatest potential impact on patient care of the more than 5,800 abstracts that have been accepted into the meeting. So this is the cream of the crop. Joining me on the podium are ASCO experts, Dr. Hal Burstein, who you heard from yesterday, Dr. Warren Chow, Dr. Monty Pal, Dr. John Haymack, who will provide additional context about the studies highlighted today. I'll just let you know that when Dr. Pal finishes his remarks later in the session, he'll need to be exiting for another engagement. So he's not running out on you, and he will be available later in the day for interviews if necessary. Remember that we ask you to use our ASCO affiliations for the purposes of attribution and your meeting coverage. So our first plenary presentation today, and the news is already out there about this one, highlights a randomized phase 3 trial exploring chemotherapy and hormone therapy compared to hormone therapy alone for women with breast cancer who have an intermediate risk of recurrence based on a diagnostic test. Please join me in welcoming Dr. Joseph Sperano, Associate Director of Clinical Research at the Albert Einstein Cancer Center and Montefiore Health System in New York and Vice Chair of the ECOG Akron Cancer Research Group. Dr. Sperano.
Well, good morning. It's my privilege indeed to present the results of this trial to you. It's the acronym for the trial is TAILOR-X or TAILOR-RX, which is an acronym that stands for Trial Assigning Individualized Options for Treatment. It's the largest adjuvant breast cancer trial or cancer trial ever performed. It was performed in six countries, 4 continents, over 1,100 sites, and includes the 20 co-authors shown here and a total of 30 co-authors in the publication that will be released later today in the New England Journal of Medicine. So the background for this was that adjuvant chemotherapy is an established therapy for women with early breast cancer. And the rationale for the TAILOR-X precision medicine trial here is what we were really trying to do is thread the needle. 50% of all breast cancers are estrogen receptor positive or hormone receptor positive, HER2 negative, and node negative, and up to 30% of these patients can have an incurable recurrence by 10 years. Adjuvant chemotherapy is typically recommended, but the benefit, absolute benefit, is small. This results in most patients being overtreated because endocrine therapy alone is adequate, but some are undertreated, and some who did not receive chemotherapy could have benefited from it. The second critical feature is this availability of the gene expression assay, the 21-gene recurrence score. We knew from previous studies that the information provided by this assay was prognostic in the sense that those individuals who had a low recurrence score had a very low risk of recurrence with endocrine therapy alone. And we knew that, or we thought we knew that we can safely spare chemotherapy in those patients. In addition, it was predictive. That is, it showed large chemo benefit when chemotherapy was added to endocrine therapy. But there was a major gap. There was uncertain chemo benefit for patients who had the mid-range score, and this was about 2/3 of all patients who were treated. So the key design elements of TAILOR-X were that patients were assigned to therapy for a low recurrence score or a high recurrence score, endocrine therapy alone, or chemo plus endocrine therapy. There was a chemo randomization for the mid-range score to determine whether chemo was indeed beneficial. There was an adjustment of the mid-range score, and it was a prospective trial that reflects the most modern chemo treatment. The design and the key elements are shown here. The eligibility included women aged 18 to 75 who had estrogen receptor positive or hormone receptor positive HER2 negative breast cancer. They met established guidelines for chemotherapy. About 10,000 women were registered, and those who had a mid-range recurrence score of 11 to 25 were randomized to the standard arm of endocrine therapy plus chemo versus the experimental arm. The statistical plan was a non-inferiority design, which is a very rigorous type of design to prove that chemo is not beneficial. And the patient characteristics, median age was 55, a third of patients were 50 or under, and the majority of patients had either small tumors or intermediate grade. and standard adjuvant chemotherapy regimens were used, and endocrine therapy regimens were used. And here are the top-line results. For the primary endpoint, shown in the Kaplan-Meier curve on the right, endocrine therapy was non-inferior to endocrine therapy plus chemotherapy. The hazard ratio was 1.08. The 95% confidence intervals did not cross the hazard margin, not statistically significant. The primary trial endpoint was met. The 9-year disease-free survival rates were 83.3% for the endocrine therapy arm, 84.3% for the chemotherapy arm. Other endpoints, similar outcomes. Distant recurrence rates were 5% overall, and overall survival rates were similar at 9 years, irrespective of chemotherapy use. In terms of the other arms, for those who had a low recurrence score, there was a 3% distant recurrence rate with endocrine therapy alone. And for those who had the high recurrence score assigned to chemoendocrine therapy, there was a 13% distant recurrence rate despite chemotherapy and endocrine therapy. And a very important finding was that in an exploratory analysis in the randomized group, which we conducted to really nail down and determine whether there was, to make sure there was no subgroup who derived some benefit from chemotherapy, we found an interaction between age and recurrence score. So the younger woman, 50 or younger, who had a recurrence score of 16 to 25, had some chemo benefit. And there were 2% fewer recurrences for a recurrence score of 16 to 20, and 6 to 7% for those with a recurrence score of 21 to 25. And this is information that could drive some women, younger women, who have a recurrence score in this range to accept chemotherapy. So in terms of the big picture and the impact on care, application of this test in clinical practice to this population would be estimated to spare chemotherapy in about 70% and to select chemotherapy in about 30% on average. Thank you for your attention.
Thank you, Joe. So as we've done in these press briefings, we're going to hold all questions till all the presentations have been made, but I'm going to call on a few of our experts to add some color commentary, and I'd like to ask Dr. Burstein to make some remarks.
Thanks, Rich. So these are very important data because this is the most common form of breast cancer in the United States and developed countries, and the most challenging decision we make with these patients is whether or not to recommend adjuvant chemotherapy with all of its side effects and with its potential benefits. And for those of you who have ever been a clinician in a consultation room or a patient in a consultation room, you know there's a huge difference between saying, well, you might benefit a little bit, and saying there's no benefit for you. And what the data provided here today from this massive NCI-sponsored trial show is that the vast majority of women who have this test performed on their tumor can be told that they don't need chemotherapy, and that can be said with tremendous confidence and reassurance. Now, it must be acknowledged that over the past 12 years, we've been using this test on a day-to-day basis. So you might ask, why did we need this investment to validate that experience? And I think it's important for several reasons. First, the original data for use of the Oncotype DX recurrence score were based on chemotherapy regimens that were 25 years old now. And so the question has been, if we use modern chemotherapy, would the results be different? Secondly, we've improved our endocrine treatments, our anti-estrogen approaches, which also might have affected these results. Third, it's important to have a prospective validation of the data. And finally, there was a gray zone, an intermediate zone, where it was unclear what the magnitude of benefit for chemotherapy might be, and this created practical decision-making challenges for patients and for clinicians. So as you just heard from Joe Sperano, the results are clear. For almost all women who have tumors with recurrence scores less than 25, there will be no role for chemotherapy. There will be discussion for the small group of women who are less than age 50, who have intermediate range recurrence scores on the order of 20 to 25, as to whether they need chemotherapy or whether using an alternative endocrine approach, such as ovarian suppression, might accomplish the same goals. That leads me to the point, which is this is not so much about de-escalation, which is a phrase that many of the media had picked up on. The goal of this study was not to just use less treatment. The goal was to tailor treatment. They chose the title very aptly, with the idea of saying some women are going to need more of one kind of therapy and less of another, and others will get a different treatment based on the biology of their tumor. So this is an extraordinary day for breast cancer doctors and for women who have breast cancer. It allows us to individualize treatment based on extraordinary science, which now has tremendous prospective validation, an investment I would again echo, supported by the National Cancer Institute. There will be questions moving forward about how we can extrapolate these data to higher risk women and to other assays that have similar results. But for today and for the weeks to come, it's a very powerful finding. And in listening to Joe, I just wanted to make one more point, which is that even in the highest risk group of patients here, the ones who got chemotherapy and hormone therapy because the oncotype scores were in the high range, the 10-year disease-free survival was 87%. We've made extraordinary progress in the way we are managing breast cancer. In the low-risk group, the 10-year recurrence rate is less than 5%. So women with breast cancer who are getting modern therapy are doing extraordinarily well, and this test shows us how to tailor that management so they get exactly the right amount of treatment, not too much and not too little.
Thanks, Hal. Great comments. I just wanted to add two things. We talk a lot at these meetings about diagnostic tests and whether they're well validated or not. And the series of studies over many years now, culminating in TAILOR-X, all performed using the Oncotype DX test, I think is a paradigm for how diagnostic test development should be done, going from sort of retrospective analyses of completed clinical trials all the way through now to a large prospective randomized clinical trial that shows such a definitive and important role for this particular test. But I'm not talking so much about the test itself as about the process, which I think is important to keep in mind. The other thing I just wanted to say, because I just would be remiss if I didn't say it, this study, as you heard, was initiated by the Eastern Cooperative Oncology Group, ECOG, and I would be remiss if I didn't acknowledge the key role of my good friend and colleague, Dr. Bob Comas, who was the group chair of ECOG when the study was conceived, who was a driving force in bringing it to fruition, and who sadly passed away last year. But this is such an important part of Bob's legacy. So let's go on to our next speaker. Our next presentation features findings from a randomized phase 3 trial adding low-dose maintenance chemotherapy after standard treatment for children with high-risk rhabdomyosarcoma, a rare cancer of the muscle tissue. The lead author is Dr. Gianni Bisogno, a professor at the University Hospital of Padova in Italy and chair of the European Pediatric Soft Tissue Sarcoma Study Group, and he will present the study.
Thank you. I'm very glad, and it is an honor for me to present here the result of the RMS 2005 trials that has been performed by the European Pediatric Soft Tissue Sarcoma Group. You have heard Dr. Sparano talking about a very frequent cancer. Now I'm talking about a very, very rare cancer. You can see here the number of new diagnoses per year we expect in the United States and Europe. But here in ASCO, I would like to underline that 40% of all rhabdomyosarcoma diagnoses occur in adults. And with modern treatment, we are able to cure up to 70–80% of children. Our group was founded in 2001, and it includes 14 countries with more than 100 centers. We have been working for over 10 years to perform these trials. And here you see we enroll all patients with high-risk rhabdomyosarcoma up to the age of 21 with no evidence of metastasis at diagnosis. And the standard treatment, it is composed by 9 cycles of intensive chemotherapy, surgery, and or radiotherapy. And this is what we are using in Europe, and it is very similar in the United States. At the end of this treatment, more than 90% of children have no evidence of tumor, but we know that after, and the idea is that we know that after 1 year, 2 years, 1/3 of these children relapse and most of them die. So our idea was to add some more treatment in a special way. You see here the regimen we have adopted is a low-dose chemotherapy, much less intensive than the chemotherapy these children usually receive, with vinorelbine given weekly and cyclophosphamide given every day by mouth. So in our trial, we randomize all high-risk rhabdomyosarcoma patients with no evidence of tumor at the end of starter treatment to stop the treatment or to receive a maintenance for 6 more months. And we include in this trial 371 children, equally distributed in 2 arms, and all the clinical characteristics were well balanced. As expected, the treatment toxicity was low, was much lower in comparison to what we usually see with standard intensive chemotherapy. We had less anemia, less neutropenia, less thrombocytopenia. We had less episode of infection, and we didn't see any important organ dysfunction. And here you can see the results. Patients receiving maintenance treatment had a disease-free survival of 8% higher in comparison to those that stopped treatment, and overall survival was even better. The children receiving maintenance had a 13% increase on survival. So at the end of this long, not easy study, we concluded that maintenance is an effective and well-tolerated treatment for children with high-risk rhabdomyosarcomas, and our group decided this is the new standard treatment for patients. At least in Europe, we give standard intensive chemotherapy, and then we continue with 6 more months of low-dose chemotherapy. And we also think that this approach, this new way we are using these old drugs, can be of interest also for other pediatric tumors. Thank you.
Thank you very much. It's always remarkable to me how the pediatric oncology community manages to continue to make great strides by using old drugs in new ways. So I'm going to ask ASCO expert Dr. Warren Chow for some comments and context about this study.
Thank you, Dr. Shilsky, for the opportunity to place this important study in perspective on behalf of ASCO. The addition of 6 months of low-dose daily cyclophosphamide and weekly Vinorel being 2 clinically approved chemotherapies significantly improved 5-year overall survival, nearly 13% with few serious side effects with in high-risk embryonal and alveolar rhabdomyosarcoma patients. As Dr. Bisogno said, rhabdomyosarcomas are rare pediatric muscle-derived tumors that are even rarer in adults. In this Italian-led European trial, patients less than 21 years of age who completed standard therapy were eligible to be randomized to maintenance or observation. The results show improved 5-year overall survival from 73.7% to 86.5%, thereby establishing maintenance chemotherapy after standard therapy as the standard of care in the European consortium. It did take this multinational European cooperative group more than 10 years to complete this trial, demonstrating the rarity of this tumor and difficulty in completing such a trial, but more importantly, how to successfully conduct large and important trials in rare diseases. Since there are slight differences in how rhabdomyosarcomas are treated in the United States versus Europe, these results will need to be tested in the United States with US-based protocols before becoming standard of care in the United States. Also, we'll need to determine if these results are applicable to patients older than 21 years of age who are considered high risk based solely on their age. Even with these caveats, this is the first significant treatment advance in this rare cancer in more than 30 years. No doubt, this trial was a home run.
Great, thank you. Dr. Bisogno, I have a quick question for you about this study. This way of giving chemotherapy, prolonged administration of very low doses, has been referred to in the past as metronomic chemotherapy, which when that concept was first introduced now quite a few years ago, was thought to potentially kill cancer cells by inhibiting blood vessel formation as much as by directly attacking the cancer cells. Do you think that's what's going on here?
This might be one of the explanations. There are three explanations. I think this will be debated in the afternoon: the duration, the type of drugs that we are using, and the metronomic approach. Maybe altogether, these 3 different actions have been of benefit to increase the survival.
Okay. Well, we'll look forward to that discussion in the plenary session then. Thank you. So our next presentation highlights results from a randomized phase 3 trial examining the need for surgical removal of the kidney, or so-called nephrectomy, in patients with metastatic kidney cancer. The lead author is Dr. Arnaud Mijon, a urologist at the Department of Urology at the Hôpital Européen Georges Pompidou, Paris Descartes University in Paris, France. He will present the study.
Thank you. Yes, it's also for me a pleasure and a great privilege to present in this fantastic plenary session of the ASCO. I would like to present this challenging surgical trial, cytoreductive nephrectomy followed by sunitinib versus sunitinib alone in metastatic renal cell carcinoma. The background of this study was that kidney cancer accounts for 5% and 3% of all cancers in men and women respectively, and approximately 20% of these are metastatic at diagnosis. For the past 20 years, the standard of care for these patients had been surgery and systemic therapy. At this time, it was the cytokines and interferon. But since 2005, with the advent of targeted therapies, the standard of care has changed, and treatment became nephrectomy plus sunitinib. However, the role of nephrectomy in this era of targeted therapy is in question and has been addressed by multiple retrospective studies. So we try to design a study to know if it is still necessary to operate these patients with synchronous metastatic kidney cancer. So let me take a few seconds to explain the clinical situations that we typically have. Number one, patients with kidney cancer, good performance status, and small metastatic tumor burden, like, for example, small lung mets. And for this patient, nephrectomy is certainly useful, and treatment is commonly delayed. The second situation is patients with kidney cancer, bad performance status, and a high volume disease. And for these patients, unfortunately, nephrectomy is not useful, and systematic treatment has to be started quickly. And patients with kidney cancer, performance status 0 or 1, limited metastatic tumor burden, who knows if nephrectomy is necessary? Carmela was exactly designed for these patients to test the benefit of initial nephrectomy against the benefit provided by targeted therapy alone. So Carmela was a big study, 450 patients, 79 centers from France, the UK, and Norway. Inclusion time was over 8 years, between 2009 and 2017, and with the multidisciplinary approach, including urologists and medical oncologists. So the design of the study was to include 450 patients with clear cell RCC confirmed by biopsy, documented metastatic disease, patients were 0 or 1 performance status, amenable to surgery, and eligible for sunitinib. Patients were stratified according to the MSKCC's classification in 2 groups, intermediate and poor risk groups. The question is why there is no good prognosis factors for these patients. It is because, by definition, these patients were excluded from the good performance status because they have synchronous metastatic kidney cancer. Patients were randomized 1:1 between the arm A, the standard of care, 226 patients. We have a nephrectomy and sunitinib, and the experimental arm, which included 224 patients. The primary endpoint was the overall survival, and secondary endpoints were PFS, the tumor response, the clinical benefit, and safety. This is the results of the primary endpoint. The Kaplan-Meier curves indicated the percentage of patients who are alive at 1, 2, and 3 years according to the treatment in red, sunitinib alone, and in blue, patients with nephrectomy plus sunitinib. Median overall survival was higher in arm B, sunitinib alone, than arm A, 18.4 months versus 13.9 months, with a median follow-up of 50.9 months. The non-inferiority condition was met with an hazard ratio of 0.89, and the confidence interval was superior to 1.20. Conclusion: sunitinib alone is not inferior to nephrectomy followed by sunitinib. Carmela was a non-inferiority study. Non-inferiority for OS was demonstrated in patients with both intermediate risk and poor risk group. PFS and clinical benefit were greater with sunitinib alone compared with nephrectomy, and we propose that when medical treatment is required, sector-reductive nephrectomy should no longer be considered the standard of care for these patients with synchronous metastatic RCC. All the results and data will be published tonight in the New England Journal of Medicine. Thank you.
All right, so after you come to the plenary session, then you can read the New England Journal paper. So I'd like to ask ASCO expert Dr. Monty Pal to offer some comments and context.
Thanks so much, Dr. Shilsky. We don't often talk about kidney cancer in these sessions, but it's a disease that affects about 60,000 patients a year in the U.S. Many patients with kidney cancer will evolve to have metastatic disease, principally it would spread to the lungs, lymph nodes, and other organs, and it causes a significant toll, about 15,000 deaths per year. Now, the prognosis for advanced kidney cancer has actually improved markedly over the past decade thanks to the advent of targeted therapy. What we've seen is an improvement in median survival from about 1 year more than a decade ago to closer to about 3 years at this point in time. And that's really on account of the drug-based therapies that we're using in this disease. Now, one of the practices that we've really held to is even in the context of patients with advanced disease who have spread to the lungs, liver, and other sites, we've been removing the kidney, but admittedly this isn't based on a very high level of evidence until now. What I will say is that this clinical practice is based largely on surveys of national data repositories and data banks performed by investigators like myself and many others. And what we've shown in these retrospective studies is that there seems to be benefit with this approach. But again, the highest bar is what Dr. Magin has presented, and that's a randomized prospective clinical trial. What he's done is he's firmly demonstrated, in my opinion, that in the context of the targeted therapy sunitinib, there doesn't necessarily seem to be a need to remove the kidney in patients with advanced and metastatic disease. He's really sort of flipped the existing paradigm that we have in the management of advanced kidney cancer in this regard. But what I will say is that we need to take these results with a grain of salt because the treatment landscape for advanced kidney cancer is evolving very rapidly. In January of this year, we had the approval of cabozantinib, which is a multi-kinase inhibitor that may potentially obviate treatments like sunitinib that was the base of this particular clinical trial. Perhaps even more of an evolution has taken place since then with the approval of nivolumab and ipilimumab, a dual immunotherapy regimen for advanced kidney cancer that happened in mid-April of this year. And again, I think in the context of these newer therapies, we may potentially have to go back to the drawing board once again and assess the relevance of removing the primary tumor in this case. Thank you.
Thank you, Monty. Just one other comment I wanted to offer that occurs to me listening to this study and the TAILOR-X study, both of which were designed as non-inferiority trials. There's been a lot of discussion in the press recently about this issue of small trials and big trials, and do we really need big trials anymore, and things of that sort. You can't answer questions like this with small trials. These are questions and trial designs that require large numbers of patients to produce the definitive results that you've seen. And there are many other kinds of questions that you can answer with small trials, and the whole issue of the trial size and the trial design really is driven by the objectives of the study. So I just wanted to put that out there to you because I think these are great examples where large trials with large numbers of patients have produced very definitive results. Our final presentation today will discuss a randomized phase 3 study studying the immunotherapy drug pembrolizumab versus platinum-based chemotherapy for advanced non-small cell lung cancer that expresses lower levels of PD-L1. And to give that presentation, please welcome Dr. Gilberto Lopez, a medical oncologist at the Sylvester Comprehensive Cancer Center at the University of Miami, and I'm pleased to say the editor-in-chief of ASCO's Journal of Global Oncology. So, Gilberto.
Very good morning, everybody. I hope you can hear me well in the back. Welcome to ASCO, and I'm very happy to be here to talk to you about lung cancer. Lung cancer is a very dreadful disease. Every year we have more than 230,000 patients develop it, and 150,000 die from this disease. That's the equivalent of the whole population of Kansas City, Kansas, dying every year. It's a huge healthcare problem, and it's a healthcare problem that we have just started to improve over the last few years. Despite having a very effective screening test as low-dose computed tomographies, fewer than 2% of eligible patients in this country actually do get this screening test. And we know that from an abstract that was presented here at ASCO a couple days ago. My talk has a subject, patients with more advanced disease, for which the disease is even more dreadful, because most patients historically died within 12 months. What we have seen over the last few years is that a combination of new agents, including targeted agents and immunotherapies, has helped patients live a little longer, but we still have a lot of effort and a lot of work to do. The specific presentation that I'm showing at the plenary session later on today is a comparison of an immunotherapy, an immune checkpoint inhibitor called pembrolizumab, which blocks a molecule called PD-1, versus standard chemotherapy for patients who had advanced non-small cell lung cancer and who also expressed a marker called PD-L1, which has helped us see in the past which patients tend to do better, and that's why we wanted to test this population with patients with an expression of at least 1%. And this is what I just mentioned to you in this background. It's important to notice that in this trial, we did not enroll any patients with EGFR mutations or ALK translocations who would actually have been better candidates for tyrosine kinase inhibitors, which are oral targeted agents. And these are the main results of the trial. In this trial, we sequentially tested 3 different populations with expressions of 50% or greater, 20% or greater, or 1% or greater. So the slide that you do see is the slide for the whole population of the trial. And here we see that the overall survival improved from 12.1 months with chemotherapy up to 16.7 months with immunotherapy with the agent pembrolizumab. For patients that have an expression of 20% and above, those numbers are actually 13 and 17.7 months. And for patients who expressed at least 50% of PD-L1, the median survivals were 12.2 months and 20 months. In addition to that, those patients that had responses to pembrolizumab had responses of much longer duration, as we see in this slide. The figures show you the responses for chemotherapy in orange and for immunotherapy in blue. You can see that those numbers are overall very similar, but if you see below the bars, you can see the duration of response, which varied from 10.8 to 20 months for the patients with a tumor proportion score of 50%. And I'll mention also for the group of 1% and above, for which the duration of response went from 8.3 also to 20.2 months. And these are responses that are unlike anything that we have seen with chemotherapy in the past for non-small cell lung cancer. In addition to that, and probably more importantly, patients had fewer adverse events. Overall, about 60% had any treatment-related adverse events with pembrolizumab versus 90% with chemotherapy. For severe treatment-related adverse events, grade 3 or 4, 5 as we call in the trial, only 18% of patients in the pembrolizumab develop those severe side effects versus 40% for patients who receive chemotherapy. And these are our summary and conclusions, and we have more data that we'll present in the afternoon, and we're looking forward to the discussion, but we can come to the conclusion that pembrolizumab becomes an option for patients who have advanced non-small cell lung cancer who do not have EGFR mutations and ALK translocations, and who do express PD-L1 at least the 1% level. We do need to do a lot more work. Even though patients do better today, they still do not do well enough. The vast majority of patients with advanced lung cancer will have disease progression and will succumb to lung cancer, so we do need to continue doing a lot more work. We are seeing new studies at this ASCO as well using combinations of chemotherapy and immunotherapies. We are looking at combinations of immunotherapies, and we hope that in the next few meetings we're going to see results that are even better than the ones I'm showing here today. For your time and attention, I thank you.
Thank you so much, Gilberto. So I'm going to ask Dr. John Haymack, a lung cancer expert at MD Anderson and ASCO's expert on this topic, to give us some comments and context.
Okay, well, thank you, Dr. Shilsky. As you'll know, non-small cell lung cancer remains by far the leading cause of cancer deaths, both in the U.S. and worldwide. This study represents a true milestone for the field because now, for the first time, we can say that non-small cell lung cancer patients receiving first-line therapy, the vast majority can receive immunotherapy with pembrolizumab instead of chemotherapy and receive substantial benefit. Prior to this time, the KEYNOTE-24 study had shown about a third to a quarter of patients with high PD-L1 levels receive substantial benefit, both in terms of survival and progression-free survival with pembrolizumab as compared to chemotherapy. This now more than doubles that population that can start with immunotherapy as a first-line treatment, assuming the FDA modifies the label in accordance with the study. I really view this as a double win for patients. Often advances in survival for our lung cancer patients come at the cost of significant toxicities. Here, by contrast, not only are patients living longer and have a much higher likelihood of prolonged survival in years, often instead of months, but they're also receiving a treatment that has substantially less toxicity across virtually all measures. And I'm going to tell you this really impacts the day-to-day life of these patients. Typically, with chemotherapy, patients, when they come in, are dealing with a host of side effects, including myelosuppression or suppressed immune system, nausea, hair loss, numbness and tingling in their fingers and toes. This treatment is really dramatically better tolerated than any of those. And while there are toxicities, they're typically easily managed and reversible upon stopping the drug. So if you take this study and couple it with earlier studies like KEYNOTE-24 and the earlier CheckMate 227 study, we're now leaving an era where the only choice for non-small cell lung cancer patients is to start with chemotherapy, because now we can say that the vast majority of patients can potentially receive benefit from immunotherapy instead of chemotherapy. Now, there are still important unanswered questions, of course, but there's a host of studies addressing these. For example, are there some patients for whom immunotherapy with chemotherapy is superior to immunotherapy? Are combinations of immunotherapy going to be superior to a single agent? How do we integrate targeted agents? And how do we deal with tumors once they've progressed after PD-1 monotherapy? But those will be addressed in time. For right now, I think this represents an important milestone because an era in which chemotherapy was the only option for non-small cell lung cancer patients is drawing to a close. Now virtually all non-small cell lung cancer patients can receive a non-chemotherapy regimen, either with immunotherapy or if they have a driver mutation with an appropriate targeted agent. So immunotherapy is here to stay for the vast majority of non-small cell lung cancer patients as first-line treatment, and this represents a real important advance for patients.
Thank you, John. It really is quite remarkable. I think if any of you were at yesterday's opening session and heard Dr. Johnson's presidential address, you noticed that he showed a slide from an ECOG study that was presented at the plenary session, I think it was 2002, which was comparing 4 different chemotherapy doublets, as they were known, in the treatment of patients with advanced non-small cell lung cancer. And the big news at the meeting was that the outcomes were equally bad with all 4 doublets, and some were less toxic than others. And that made the plenary session, and that was a paper published in the New England Journal, and it was thought to be a study that provided great insight into lung cancer treatment. So now here we are, nearly 2 decades later. But the landscape is so completely different, it's quite remarkable. We're now talking about a time when we're not even going to use chemotherapy in treating non-small cell lung cancer. So quite a remarkable paradigm shift.